Assalamu alaikum. Our lecture today is osteointegration, biological events in relation to dental implant. Dental implant or fixture is a surgical component that interfaces with bone of the jaw or skull to support a dental prosthesis such as a crown bridge denture, facial prosthesis, or to act as orthodontic anchor. The basis for modern dental implant is a biological process called osseointegration, where materials such as titanium form an intimate bone-to-bone. The utilization of dental implant became a scientifically accepted treatment modality for the rehabilitation of fully and partially edentulous patients because it can offer a number of benefits from improved aesthetic to reducing bone loss to bone-to-implant interface. Two basic theories: osseointegration by Primark in 1985 or fibro-osseous integration by Lincoln 1976. Fibro-osseous integration: presence of connective tissue between the implant and bone. Collagen fibers function similarly to Sharpie's fibers found in natural dentition. The fibers are arranged irregularly parallel to the implant body. When forces are applied, they are not transmitted through the fibers. Failure of fibro-osseous theory: no real evidence. Forces are not transmitted through the fibers. Remodeling was not expected. Forces applied resulted in widening fibrous encapsulation, inflammatory reaction, and gradual bone resorption, thereby leading to failure of dental implant. So the osseointegration is the best. Osseointegration implant is a type of implant defined as an endosseous implant containing pores into which osteoblast cells and supporting connective tissue can migrate. Applied to oral implantology, this refers to bone grown right up to the implant surface without interposed soft tissue layer. No scar tissue formation, no cartilage or ligament fiber are present between the bone and implant surface. Osseointegration of titanium implant is a complex biological process involving interaction between immuno-inflammatory responses, angiogenesis, and osteogenesis, all of which are influenced by the physical and chemical characteristics of the implant surface. An implant surface with moderately rough topography and high surface energy influences cellular activities, enhancing peri-implant bone wound healing. Primary mechanical stability of the implant is essential. Definition of osseointegration: the word of osseointegration consists of two: osseo, which is the Latin word for bone, and integration, derived from Latin also, meaning the state of being combined into a complete whole. Osseointegration is defined as a direct bone anchorage to an implant body, which can provide a foundation to support a prosthesis. Direct structural and functional connection between ordered living bone and surface of a load-carrying implant. American Academy of Implant Dentistry defined the osseointegration as a contact established without interposition of non-bone tissue between normal remodeled bone and on implant, entailing as suspension, transfer, and distribution of load from the implant to and within bone tissue. The factors that influence the osseointegration is the surgical factors and patient-related factors. The implant-related factors include Implant biomaterials or biocompatibility between the bone and the implant surface, implant biomechanics, implant design, implant taper, apical design, implant width, crest module design, implant surface topography or surface roughness, implant surface modification, contamination, and heat production during surgical preparation. Biocompatibility has been defined as the capacity of the material to exist in harmony with the surrounding biological environment, not having toxic or injurious effect on biological function. Key factors that influence the benefit and maintenance of the biocompatibility include corrosion resistance of the material, cytotoxicity of corrosion products, and metal contamination. This is the titanium surface, and this is the layer of oxide, and this is electrolyte. Grouping of hard tissue replacement material according to their compatibility to bony tissue. Biotolerant material, characteristic of reaction of bony tissue, implant separated from the adjacent bone by soft tissue layer along most of the interface, distant osteogenesis. The material like stainless steel and COCR alloy. Bioinner material, direct contact to bony tissue, contact osteogenesis, like lamina, ceramic zirconia, ceramic titanium, tantalum, and niobium or carbon. Bioactive material, bonding to bony tissue, bonding osteogenesis. Material like calcium phosphate containing glasses, glass ceramics, and ceramics titanium. Implant surface modification. Need for surface modification to increase the surface area, also to remove surface contamination, also to bring better bonding and to increase surface roughness of metal, to increase corrosion resistance of the metal, and finally to make the metal more passive. Heat production during osteotomy or drilling of the bone. Heating of bone to a temperature in excess of 47 degrees centigrade during implant surgery can result in cell death and denaturation of the collagen. As a result, osseointegration may not occur. Instead, the implant becomes surrounded by fibrous capsule. So, during the preparation of the hole must be irrigation with saline. State of the host bed. Ideal host bed, healthy and with an adequate bone stock, bone height, bone width, bone length, bone density. Undesirable host bed state for implantation, a previous irradiation of the bone, ridge height resorption, and osteoporosis. Patient factors include age, compromised oral hygiene, heavy smoking, anemia, vitamin C deficiency, uncontrolled periodontal disease, psychological problem, uncontrolled diabetes, radiation treatment, chemotherapy, bone density, place bone density like in osteoporosis, available bone. Mechanism of osseointegration. Blood clot between a fixture and bone, first formation, then the clot transformed by phagocytic cells like macrophage, from 1 to 3 days after implantation. Procallus formation containing fibroblast and phagocyte cells. Then the procallus become dense connective tissue, differentiation of osteoblast and fibroblast cells. Then the callus osteoblast on the fixture. Then the fibrocartilaginous callus between the fixture and the bone. Bone callus penetrate and maturate. A prosthesis attached to the fixture stimulating bone remodeling. Biological process of integration by Brainmark, author. First, osteophilic stage. Second, osteoconductive stage. And third, osteoadaptive phase. The first phase, which is the osteophilic phase. Blood clot formation, as we said before. Then the inflammatory cells infiltration to this clot. A new vascularization within 3 days. And then ossification begins during the first week after implantation. This phase lasts about 1 month. This is the fixture, and this is the bone bed, and this is the formation of a blood clot around the fixture. This blood clot contains inflammatory infiltration cells. Then the ossification is started by the formation of a newly osteoid tissue around the fixture. Osteophilic stage, when implant is placed into the cancellous marrow space, blood is initially present between implant and bone and clot. Only a small amount of bone is in contact with the implant surface. The rest is exposed to extracellular fluid. Generalized inflammatory response to the surgical insult. By the end of the first week, inflammatory cells are responding to foreign antigen. Vascular ingrowth from the surrounding vital tissue begin by the 3rd day. A mature vascular network formed by the 3 weeks. Ossification also begins during the first week, as we said before, and the initial response observed in the migration of the osteoblast from the trabecular bone or old trabecular bone, which can be due to the release of bone morphogenic proteins. The osteophilic phase lasts about 1 month. The second phase is osteoconductive phase, by the formation of woven bone, or called foot plate. Then the lamellar bone formation after woven bone. Last this phase for 4 months. This is the formation of the woven bone in the thread area of the bone, and this is the thread of the dental implant, and this is the osteoblast. Also neurovascularization inside is the woven bone, and this is the callus formation. This is the old bone. Osteoconductive phase. Once they reach the implant, the bone cells spread along the metal surface, lying down osteoid tissue. Initially, this is an immature connective tissue, matrix, and bone deposited in a thin layer of woven bone called foot plate. This is the foot plate. Fibrocartilaginous callus is eventually remodeled into bone callus. This process occurs during the next 3 months. 4 months after implant placement, the maximum surface area is covered by bone. Osteoadaptive phase. A balance remodeling occurred. The foot plate or woven bone thickened in response to the load transmitted through the implant. Some reorientation of the vascular pattern may be seen. This area of thread is filled by remodeling bone. The final phase begins approximately 4 months after implant placement. Once loaded, implants do not gain or lose bone contact, but the footplate thickened in response and some reorientation of the vascular pattern may be seen. Grafted bone integrates to a higher degree than the natural host bone to the implant. When we use the bone graft with the implant, it's the higher degree of natural host bone to implant. To achieve optimum results, an osseointegration period of 4 months is recommended for the implant in a graft bone and 4 to 8 months for implant with a normal bone without graft. Mechanism of integration by Osborn and Newesley in 1980. The term distance and contact osteogenesis were first described by Osborn and Newesley in 1980, and it referred to the relationship between forming bone and the surface of the implanted material. Their term described essentially two distinctly different phenomena by which bone can become juxtaposed to an implant surface or attached to the implant surface. First distance osteogenesis, a gradual process of bone healing inward from the edge of the osteotomy toward the implant. Bone does not grow directly on the implant surface, so this is the hole or edge of the osteotomy, and this represents the implant surface. The cells around the edge of the osteotomy became in contact with the implant surface gradually. The meaning of distance osteogenesis. In distance osteogenesis, a new bone is formed on the surface of the bone in the peri-implant size. Similar to normal appositional bone growth, the existent bone surface provides a population of osteogenic cells like osteoblasts that lay down a new matrix or in a new osteoid tissue, which has osteogenesis continuous anchored on the implant itself. Thus, an essential observation here is that a new bone is not forming on the implant itself, but rather that the implant becomes surrounded by bone. In these circumstances, the implant surface will always be partially obscured from bone by intervening cells and general connective tissue, extracellular matrix, which makes bone bonding impossible to achieve. Second type is the contact osteogenesis, the direct migration of bone building cells through the clot matrix to the implant surface. Bone is quickly formed directly on the implant surface. This is the implant and this is the cells is quickly attached to the implant surface and begin the formation of a new bone. What's the meaning of contact osteogenesis? In this process, a new bone formed first on the implant surface. Since no bone was present on the surface of the implant upon implantation, the implant surface must become colonized by the population of osteogenic cells, mean osteoblasts, before initiation of bone matrix formation. This occurs at remodeling site where an old bone surface is populated with osteogenic cells before a new bone can be laid down. These osteogenic cells migrate to the implant surface. While both distance and contact osteogenesis will result in juxtaposition of bone to the implant surface, the biological significance of these different healing reactions is of considerable importance in both attempting to unravel the role of implant design in endosseous integration and in elucidating the differences in the structure and composition of the bone-implant interface or osseointegration. Biological event associated with peri-implant bone wound healing. Irreparable bone healing after implant insertion into prepared site in the bone comprises several coordinated and sequentially overlapping biological events. Following clot formation, as we said, in the micro voids around the implant, there is an initial inflammatory response followed by a new vascularization and the formation of transient fibrin-based structural matrix that serves as the osteoconductive medium. Recruitment occurs to the implant surface of the mesenchymal progenitor cells from the bone marrow and possibly also a pluripotent periocytes from the adjacent blood vessels. The progenitor cells then differentiate into osteoblasts, which deposit an extracellular matrix that undergoes mineralization. The extracellular matrix here is the osteoid tissue. Platelet aggregation and clot formation. Several proteins like fibronectin, vitronectin, laminin, serum albumin, collagen, and osteopontin. These proteins facilitate the attachment of the osteogenic cells or osteoblasts on titanium surface because they contain specific protein sequence such as arginine, glycine, aspartic acid. The basic steps of a clotting mechanism takes place and the platelet, which play an essential role in the early stage of wound healing, aggregate producing and secreting number of growth factors include platelet-derived growth factor, transforming growth factor, beta 1 and beta 2, insulin-like growth factor, and vascular endothelial growth factor. And biological mediators include coagulative factor and vasoactive agent, which promote tissue healing and bone regeneration by stimulating proliferation of undifferentiated mesenchymal cells or progenitor cells and enhance both the differentiation of osteogenic cells and angiogenesis, thus promoting bone regeneration. The initial immuno-inflammatory response. Within 24 hours of implant insertion, a neutrophil can be observed in the peri-implant wound. Within 2 to 4 days, macrophage and monocytes appear in the peri-implant wound. Their function begins the removal of biological debris after surgical preparation and production of cytokines and growth factor that stimulate cell proliferation, chemotaxis of osteoprogenitor cells, angiogenesis, and collagen synthesis. This action of macrophage and monocytes are supported by CD4 and CD8 T cells, which are present within the hematoma in the microvoids around the newly inserted implant. Peri-implant osteogenesis. A few days after implantation, creation of non-collagenous matrix layer or cement line or called lamina limitans on the implant surface. This layer consists mostly of osteopontin and bone sialoprotein and protoglycans. Regulates cell adhesion and binding of minerals, where the initial mineralization through calcium and phosphate precipitation occurs. The cement demarcated the area where bone reabsorption was completed and bone formation initiated. Following the establishment of the calcified matrix on the implant surface, woven bone formation and organization of bone trabeculae start to take place. The newly formed bone was laid down on the reabsorbed surface of the old bone. Osteoblasts cannot always migrate rapidly. These osteoblasts became clustered as osteocytes in bone lacunae. The early trabecular bone formation ensures tissue anchorage that correspond to biological fixation of the implant. Bone particles left by after the surgical preparation of the osteotomy enhance a new bone formation, most probably by releasing osteoinductive factors such as bone morphogenic protein and by serving as an osteoconductive scaffold, and some of these bone particles are incorporated into the newly formed mineralization because it contains calcium and phosphorus. Most of the woven bone usually remodeled in 3 months post-implantation and replaced by the lamellar bone that may reach a high degree of mineralization. So at 3 months of the healing, the implant is mostly surrounded by a mixture of woven and lamellar bone. Bone remodeling is bone remodeling in contact with the implant surface undergoes morphological remodeling as adaptation to stress and mechanical loading. The turnover of peri-implant mature bone is osseointegrated. Implant is confirmed by the presence of medullary or marrow spaces containing osteoclast, osteoblasts, mesenchymal cells, and lymphatic blood vessels next to the implant surface. During the remodeling of peri-implant bone, a new osteon circle around the implant with their long axis parallel to the implant surface. The remodeled bone can extend up to 1 millimeter. Epithelial tissue. Because of the capability of the epithelium to proliferate and move over surface, the epithelium found on the edge of the surgical incision crosses the fibrin clot granulation tissue bridge, which is formed right after the implant installation. Before reaching the implant surface, the epithelium moves 2 millimeters in coronoapical direction, yielding the junctional epithelium. So the junctional epithelium is formed around the dental implant. The apical portion of the junctional epithelium is constantly separated from the alveolar bone by a non-inflammatory, collagen-rich but cell-poor zone. This zone size is about 1 to 1.5 millimeter. On the collagen-rich zone, the fibers invest on the marginal bone is somewhat parallel course to the implant surface. Connective tissue. The connective tissue around the implant neck and or abutment has long been described as scar tissue with a predominance of the collagen and few fibroblasts and vascular structure. The connective tissue zone next to the implant surface is primarily divided into 2 parts. The first is 50 micrometer inner zone that is rich in fibers, resembling scar tissue. Several scattered fibroblasts in close contact with the titanium surface maintain the seal between the peri-implant bone and the oral environment. The remaining part of the connective tissue comprises fibers running in different directions along with the cellular element and blood vessels. This picture represents the area is the normal tooth with junctional epithelium, and this is the gingival sulcus, and this regard the implant surface with contact with the junctional epithelium, and this is the crown on the implant, and this is represent also the gingival sulcus formed here, and this is the alveolar bone. Also, this picture shows how the natural tooth attached to the bone and how the implant attached to the bone, like the previous picture. This is all for this lecture. Thank you for listening.